Hello and welcome. When you think of Parkinson's disease, my hunch is you think of tremor, you think of slowed movement, you think of motor things, but along with those symptoms, there are many non-motor symptoms, and we're going to talk about these today, kind of an update. We did a show on this once years ago, and it's been a topic that people have been very, very interested in and want to know more about. So tonight with me, I have Dr. Eleanor Orehek. She is a clinical neurologist at the Noran Clinic. Delighted to have you on. It's our first time working together. And you come from Minnesota, went to college out in Colorado. And just a fun little side, she was awarded the Scholar Athlete Award of the Year in 2003 as a great basketball player. You've been here at the Noran Clinic about 3 years, got your MD degree at the U of M. So we're lucky to have her back here in Minnesota. So welcome.
Thank you. I'm happy to be here.
When we just think of the range of possible non-motor symptoms that people can have when they have Parkinson's, do you want to just list several of them?
Yeah, it can be kind of a long and overwhelming list. So a good visual of trying to think about the non-motor symptoms is you have a kind of an iceberg picture. So the motor symptoms tend to be the more visible symptoms, but you have this large underwater part of non-motor symptoms that are almost more impactful for patients, but harder sometimes to recognize because of the less visible part of them, but it can be anywhere from pain to severe fatigue, cognitive changes, mood changes, sleep difficulties, bowel and bladder difficulties, changes in blood pressure regulation. So it's kind of this long, overwhelming list, but important to talk about.
Yeah, it's important to know about and kind of realize it's not just something that's in your imagination or
yeah, exactly.
Yeah.
Yeah.
I think people are very curious, Dr. Orehek, about the stages of Parkinson's. And I know it varies, of course, from person to person, but what can you tell us? Apparently there are 5 sort of official stages.
Yes, there are 5 stages, and they're based on the motor stages of Parkinson's, and they're fairly broad, so it does create a challenge when you're trying to talk to patients about what the future looks like and prognosis, because it doesn't really give you a great idea of what year to year is going to look like. But stage 1 is where symptoms affect more just one side of the body, which is often when patients come in to be diagnosed. Sometimes it's not till stage 2 though, especially if they don't have any tremor, because then it becomes harder to recognize and diagnose some of the symptoms. But stage 2 would be when symptoms affect both sides of the body. Stage 3 would be when it starts to affect more balance difficulties. So there's some mobility difficulties in that stage. And then
So with falling?
Yes, falls can start to become a challenge, which is one of the big things we're trying to prevent, because if you cause a fracture or something, that can be really hard for patients. Stage 4 would be really more significant balance difficulties, so usually requiring some assistive device to walk. And then stage
like a walker
or cane.
Okay.
And
but
then
not wheelchair usually at that
Not wheelchair
point?
yet at stage 4.
Okay.
And then stage 5 is when there's more wheelchair dependence, sometimes even bedridden, advanced stage or end-stage Parkinson's, requiring more one-to-one nursing care in that stage.
Okay. And is there a time framework that we could say is kind of an average after diagnosis, how many years people deal with this?
I don't love to put a time frame on things, just because then people feel like there's kind of this end in sight. But
and it must vary
it
tremendously.
It varies a lot from Parkinson's patients.
Yeah, that's
People with Parkinson's are kind of like snowflakes, we like to say, because everyone's different. But everybody spends probably a few years in each stage, I would say. But you're looking at going 15 years, 20 years probably before you reach end stages.
Okay. And Yeah, so that's a great range in terms of when people first are diagnosed. I mean, we all know about Michael J. Fox, and he
Right.
was in his late 20s or early 30s.
Yes.
But more commonly, it's in the 60s, 70s, correct?
When people are diagnosed with it?
Right.
Yeah,
More commonly.
Right, yeah, mid-60s is the average of diagnosis, so 60 and above. But it is important to remember that people in 20s, 30s, 40s can get this too. And so we see a lot of young patients that get misdiagnosed when they're young because people think, oh, it can't be Parkinson's, but it is. So it's important.
And is there any number that says, when we look at the whole population of persons with Parkinson's, that a certain percentage are the young diagnosed patients?
Yeah, I don't know the exact percentage, but it's in the lower 20-30%, I would say. Yeah.
Okay. Do all people, Dr. Orehek, experience the non-motor symptoms? I'm guessing the answer is yes, but I've not read that.
So yeah, I mean it's nearing 100% if you're looking closely at Parkinson's patients that have at least one non-motor symptom. It would be, the numbers are at least 90, if not higher, 90%.
Do they cluster in terms of the symptoms, in terms of anything we could, pinpoint, measure, like more women than men, younger versus older? Are there clusters of symptoms that
there
you
can
see?
be, yeah, there can be. I mean, in women, we see a higher incidence of anxiety, and it tends to be more severe anxiety. Depression is pretty equal with men and women, but tends to be more severe in women. There's more apathy. Apathy is kind of that lack of motivation that patients can get, and that tends to happen more with men, but it's not a clear kind of only happens in one or the other. And then with age, it's kind of looking at younger patients tend to have a lot of what's called dystonia, which is severe muscle cramps that can happen, and that can cause a lot of pain. So when you're thinking about pain from dystonia, it's more in the younger population. And then older patients tend to have more of the cognitive changes or a high risk of dementia.
Which makes sense when you think of
Yes.
people aging without Parkinson's.
Right.
Dementia's a pretty high-risk thing for a lot of people.
Unfortunately, yes.
Unfortunately,
That's right. Yeah.
Is the dementia you see with Parkinson's different than the dementia you see with just general aging?
Yes, and dementia is one of those tough terms that I think people have a hard time understanding because it has the stigma attached to it and kind of what is dementia, and I get a lot of people, for example, for Alzheimer's asking me, is it Alzheimer's or is it dementia, which they go hand in hand. So dementia is kind of the broad term, and then there's different causes of dementia. So Alzheimer's disease would be the most common cause of dementia, and then Parkinson's disease is another cause, and then there's dementia with Lewy bodies, which has some characteristics of Parkinson's, and people with a lot of strokes can end up with dementia. So there's a lot of paths to lead towards the end point. So it's complicated.
I suppose in some ways it doesn't matter what kind of dementia you have. It's tough to treat dementia.
It is tough to treat dementia, and we can test people on some areas because there's all these different areas of thinking and memory, and so things like Alzheimer's affect short-term memory much more than other things, and Parkinson's has different effects on thinking and memory. So if you test people, it can help sort out not only what pattern of dementia they have, but also these are the things you might be struggling with, and so these are the areas we could try to help or work on, and so that can also improve quality of life and recognizing
so
recognizing
in that
things.
sense,
Yeah,
that's important.
That it can be helpful.
Yeah,
right.
Very helpful. I've read that the non-motor symptoms that you've described and listed can precede, and often do precede, the actual diagnosis. In other words, people might, have these symptoms much earlier, but I'm so curious. I've not learned about this in the past, and how early do those symptoms start, and what are the common first symptoms you see?
So there's a few symptoms that we look at as almost being premotor symptoms. So we're looking at these symptoms as being, okay, are these actual symptoms of the disease early on, and would they be markers of being able to diagnose the disease earlier?
That's a good word for us to understand, isn't it? Markers.
Right. Yeah. So loss of sense of smell can be an early one, but that often people don't even recognize. Like, it's fairly prominent among patients with Parkinson's.
Really?
Like at least 90% or more have some degree of loss of sense of smell. And sometimes it's just reduced, and sometimes it's complete. And obviously when it's completely lost, they are more aware of it, because then it affects taste and it can affect their appetite. So that's important to recognize, but a lot of times they don't even know that their smell is affected, because it develops slowly.
Subtle loss, yeah.
Yes,
okay.
It's kind of like people with who develop cataracts. That's kind of a widely recognized thing, that it's like you don't realize how it's affecting your vision until they're removed, and then it's like, oh my gosh.
What was I missing?
Right. So these kind of things in Parkinson's can develop so slowly that you just adapt to it and you don't recognize it, how much it's affecting you. So
loss of smell.
Loss of smell, and then sleep disorder, specifically the REM behavior disorder that people can get. So that's where you act out your dreams in your sleep, because you're supposed to normally not be able to move when you're dreaming, which is a good developmental and term evolutionary.
With someone.
Right. So when in Parkinson's, the pathology can affect the area of the brainstem that's supposed to keep the muscles paralyzed during sleep. So when that happens, then people can act out their dreams, and that can lead to a lot of injury, or certainly disruption of the bed partner. Yes, and it can be dangerous. So if someone sleeps alone, it's not often recognized until it does lead to like them falling out of bed or something like that, and they don't know it's a problem.
Or sleepwalking and doing something crazy.
So those are two, and then constipation would be another one, but that's so common that it's harder to know
say if that's a variable or not, but that's one of the big three then, huh? Okay, interesting. And how early do these show up typically before the motor symptoms?
They can be 10 years or more.
Oh my goodness. Does it behoove people to pay attention to these and say to their doctor, I'm having, an unusual amount of the REM kind of disorder symptoms, or I'm not smelling? And what would the doctor, do you think, do? I mean, the average family practitioner or internist, would they make that connection?
So the most common scenario would be the sleep disorder, because people rarely would go in and say, I'm losing my sense of smell or taste. I mean, and that can be something that can be looked at, and it would be, I think, a challenging situation for somebody. Certainly sleep doctors that are treating people with REM behavior disorder have this difficult conundrum of explaining that, they're kind of obligated to explain this, you have this risk of developing Parkinson's, but it's also hard because we don't really have something that we can tell patients to do. The most we have is say, exercise as regularly as you can and as often as you can, because exercise can definitely help prevent the disease or delay progression of the disease. So that's something that we can tell patients, but everybody should be doing that anyway. So
right, and we'll talk a little more about that, because it's one of the real positive things that is the action step, isn't it?
Right, yes, that's my number one treatment plan that I talk about with people is what exercise are you doing, how much are you doing, and because it's the benefits of it.
An anecdotal thing, but one of the persons I know who has Parkinson's exercises so diligently and regularly, and her doctors are so pleased with how she's held her disease kind of, from progressing a lot.
Right.
And so
it can make a huge impact.
Can it? Let's talk a little more in depth now about some of the symptoms you mentioned. And one, I don't know if you mentioned this or you said them quickly and I didn't hear it, but pain. And that's one I've not associated with Parkinson's, but explain how that can be a symptom and is a symptom.
Yeah, so pain is one of those tough ones because especially in older people, there's a lot of things that can cause pain, and arthritis being a common one. And so I think people with Parkinson's attribute the pain to other things because it's kind of like, well, my shoulder hurts, so it must be a problem with my shoulder. And so when you're seeing someone with Parkinson's, I try to, okay, where is the pain? And so the goal is to sort out, is it something else that's treatable, or may this be part of the disease? And then talking to patients about, okay, well, if they're on dopamine medications, is there a change we can make in the medications that might help with that?
And dopamine actually does reduce the level of pain some, doesn't it?
It can, especially if so the motor symptoms, which would be stiffness, the rigidity that people have, or the dystonia, that's that painful muscle cramping. So if you treat those symptoms with dopamine, then that can help with the pain associated with those symptoms.
Sure, I see. So it's really kind of a parallel thing, though, that's going on, right?
But there can also be pain that wouldn't be related to dopamine pathways because there's other areas of the brain affected with Parkinson's that we don't talk about as much, but serotonin can be affected, and norepinephrine is another brain chemical that can get affected. And so the brain just processes pain and sensory information differently in Parkinson's, and so that can lead to worse pain than you might otherwise have if you didn't have Parkinson's.
So talk to your doctor about it, though, right?
Definitely.
Don't feel you're
I mean, pain is
overreactive.
Right. Pain is important to address, and there might be non-Parkinson's causes for the pain. So it's always important to say, patients always struggle with that. Well, is this a Parkinson's symptom, or is it related to something else? And I always urge people, well, just talk to me about it, and we'll sort it out. You don't have to. You don't have to decide if it's
right. That's a common reaction, I think, on patients' parts, though. But to share.
Right.
Bladder problems, another common symptom that goes along with Parkinson's. Specifically, what kind of bladder problems?
So specifically, it can be overactive bladder. So when the bladder contracts, that can create a sense of urgency. So people feel like they're going to the bathroom frequently throughout the day or night. It can wake up, fragment your sleep because you're waking up to go to the bathroom at night. And then some urgency. So it's like, I have to get to the bathroom right now type of thing. And then especially if you have trouble moving, it's more problematic.
Right,
so
that'd be very hard.
Yes,
it's like,
and then the anxiety, and then that creates a sense of having to urinate. So it is a complicated problem, and would be something that sometimes people's reaction is to not drink water, or like, I'll just take in less fluid, which is the opposite of what you want to do. That's something I struggle with, because I think a majority of patients don't drink enough water. And so I'm always, because that can create other problems, like we'll get to blood pressure problems, and so it's really important to drink water, and then maybe not drink it right before bed so you're up all night, but more during the day, and then that can be helpful for some of these symptoms.
Some people too, I think, from what I've read, avoid social things because of the bladder issue, and that's too bad too.
Right, they don't go places unless they know there's going to be a bathroom close by. Right. Yeah.
Are there meds you can give people that help with the overactive bladder?
Yes, there are medications.
And they don't interfere much with the dopamine in a negative way? No,
not specifically with the dopamine. They can cause other problems. So they can worsen constipation, which is a Parkinson's
often
symptom.
People are dealing with.
Right, and they can sometimes affect cognition or memory, so those are things that are important to be aware of. So a lot of it is a balancing act of trying to pick kind of which symptom is the most bothersome, and if you're having side effects, how much do they impact you type of situation. So
side effects are the hardest part, I would think, almost, of being a doctor or being a patient who's got to deal with them. I mean, it's just, there are always side effects, aren't there, with almost any med?
Yes. So I spend a lot of time talking to patients about their medications, what they're on, maybe what can we pull away. Is this medication helping you? What are you taking it for? Can we
what are the
remove
trade-offs,
it? Yeah, because there's a lot of things that my last thing I would want to do is treat a symptom treat a side effect with another medication, because then you start piling these medications on, and I think people are on enough medications. So I always try to say, okay, what can we pull away? And then if it requires a medication, then just be careful about starting it and watching for side effects.
Sounds like a great strategy. Depression and anxiety, I'm guessing that just having this diagnosis would lead to some depression and some anxiety.
Yes.
So it's got to be a pretty universal accompanying symptom, right?
Yes, so some of it is related to the disease itself and its effect on the brain chemicals, and then it also is hard because you have this progressive disease, and so it's hard to know, well, what does the future look like? And you know that things are going to get worse, but you don't know when. And
it's very understandable.
Yes.
That
so it is really hard. But
would we describe it as situational depression as opposed to clinical usually?
Well, when it's related to the adjustment surrounding the disease, then yes, it would be more situational, or adjustment disorder associated with mood or with depression and anxiety. But a lot of times in Parkinson's, it's more clinical anxiety or clinical depression because of
the tougher
separate effect.
Tougher one. Cognitive changes, another hard thing to have to tell people that this goes along with it. Does it go along with it, though, in the early and mid stages, Dr. Orehek?
Not usually, no. Usually it's something that shows up 10, 15 years or more into the disease, and there's people that live a whole life with having Parkinson's and don't encounter the cognitive changes or dementia. There's always some degree, especially when you get 5, 10 years in, of some changes, so people will describe a slowness of thought, like trouble with tip of the tongue phenomenon, trying to drop the right word. So that's something to think about and talk to people about. So I don't upfront, when I'm talking to patients about a diagnosis, tell them about all the potential cognitive problems. But
because they may not get them.
Yes.
And it might be so far down the road that other things are intervening too.
Yes, exactly. But I do try to screen at each visit for any potential problems and then talk to them about that. So
sometimes with chronic disease, I think the gradual understanding of what it means to have that disease is better than getting it all at once.
Yes, it's really overwhelming if people try to get it all at once. And everybody processes information differently. So there are some people that just go out and read whatever they can and go to all the support groups and and that's fine if that's what they want to do. And I think that's good. And then they come in with their whole list of questions. And then there's other people that kind of prefer to just kind of take on things slowly. And so everybody has a
day at a time kind of people, right?
Yes, yeah.
I'm getting this time signal that we need to show the viewers some resource information. So get out your paper and pencil. We've got some really good resource websites for you and phone numbers. The first one is the Noran Neurological Clinic right here in Minneapolis on Chicago Avenue. This is where Dr. Orehek works. And the website is www.noranclinic.com. And then the American Parkinson Disease Association, of which she is the medical director. It is apdaparkinson.org. Let me say that again, apdaparkinson.org. Phone number 800-223-2732. We also are going to put up the Minnesota chapter phone number and website, so you can refer to that. And then the National Parkinson Foundation is also another big national good resource. The website parkinson.org and the 800 number 473-4636. And we'll also put up their chapter website and number. So lots of good resources. You'll find support groups listed, which I think are really, really helpful with this condition. So in our last minute and a half or whatever we've got, let's talk about treatment. There's nothing major on the horizon, but exercise, as you said, is a wonderful treatment. Can you comment on?
Yes. So there's some exciting treatments coming up, but nothing out. But exercise is something that people can do anytime, any place, and is the only thing we know can slow the disease progression, and it also has a significant impact on a lot of the non-motor symptoms that we were talking about, like pain and fatigue and sleep difficulties, and so all these things, constipation. So getting moving and exercising as much as possible is really important.
So pretty much, it sounds like most of the non-motor symptoms are impacted by exercise.
Yes, and it's a way of treating it without adding more medications, which is always my goal. So.
Yes, as you've said.
Yeah.
And maybe we can do another show sometime on some of the emerging treatments, because
that would be great.
We don't have time to go into that now, but there's always hope on the horizon, isn't there?
Yes, there is. Yeah, a lot of exciting
Well, thank
things.
you so much.
Oh yeah, it was a pleasure.
For coming down.
Yeah.
I've learned a lot, and I'm sure the viewers have, and I think the more we know as patients and as advocates for family members, the more we can help, in terms of dealing with the condition, whatever it is. So thank you for being with us. I'll be back again next week. Until then, have a very good week.